So the success of this next bit of the more informal part of this lecture is audience participation. So if we're not going to have any questions, or if we're not going to answer any questions I raise, then the next 15 minutes is going to be very boring. So let me just ask, anyone want to just comment on what the spot diagnosis is here, and whether or not you would see this in your office and decide there would be any indications for surgical treatment? Sorry? So enchondromatosis? Yeah, yeah. And what might someone's indications for treatment be? I know we've not told you anything about it, but is this an easy thing to treat or not? Challenging, yeah. Anyone want to comment about what sorts of things they can do? Do you want to? Do you do any?
I think there is shortening of the. There is shortening also, so that also we need to address along with the bump. Probably we have to exercise that and then subsequently do lengthening in future.
Yeah, sure. So is excision of these lumps and bumps, is that an easy thing to do? No. Actually, I think it's not too bad sometimes. So, for example, you may have noticed that the X-ray doesn't match the clinical picture. I couldn't find the right one yesterday. But sometimes if you've got sort of one specific lump that is causing problems, sometimes it can be a relatively simple and very rewarding job to do a limited exposure, curette out the cartilage, stimulate the bone healing, and a little bit of fingers crossed that the gap fills in, this time with bone rather than cartilage. I agree that function is the most important thing, so you must not risk stiffness, but these joints are often quite stiff anyway. So I think you should be cautious, but I think actually it's one of the rewarding things to treat from time to time, as long as you're careful. Antonio, any comments?
No, I pretty agreed with you. It's more cosmetical from some point of view, and the other side is it's a practical way to front with the most impairment of the end. So the function first, and after the aesthetically point of view.
Yeah. And the patients are usually very informative as to what they want doing, and then you can try and decide whether that's feasible or not. This is another one. Yeah. In this case, the one lump on the index finger, I did just trim that off, curette it out, and improve that function and the look of it. Now, you might think that just making one lump better isn't really cosmetically very impressive, but to the patient, and we're treating the patient, to the patient it was quite important, and it did make it a little bit more functional. But I didn't do anything very exotic in that one. Yeah.
The X-ray in the picture is not similar?
No, the X-ray doesn't belong to the patient. My apologies.
This X-ray and the
Sorry, that was I thought they were the same patient, and then I looked last night and thought, nah, I don't think so. So at least you're all awake and realising that. Okay. So we heard about this. This is a spot diagnosis, and we heard about ideas about when to treat it. Who wants to tell me, do you do any investigations for this, for a simple solitary exostosis?
Yeah. Sometimes, and this location sometimes needs CT, angio CT, because we are afraid that location of the femoral artery is just nearby. So for that we use that.
Yeah.
Not more.
No.
Generally, we not use so much diagnosis for that. It's obvious.
My registrars always say you must know about the cartilage cap, and if it's big, then it's going to be cancer. And they tell the patients that, which is very upsetting to me, because, as we heard, in children, never say never, but cancer doesn't happen. So I don't care about the cartilage cap in a solitary exostosis. I care about whether or not the solitary exostosis does require treatment or not. Can I just ask for a show of hands, who has a low threshold for operating on this? Who would be quite happy to operate on it if it was causing problems? Yeah. Good. And what do we think problems are? Yeah. Yeah. I have to say, I used to be very harsh and tell the kids there was nothing to worry about, it was just a lump, just get over it. But I think some of them are quite troublesome, and I've learned that the patient is always right. Most of them. So if the patient says it's really causing a problem, and if you know your patient and you believe the patient, then perhaps you should be doing something to help them. I quite agree. And as we heard, of course, we have to always look, and even if we think it's a solitary exostosis, we should do a very careful examination. Would people feel that with a solitary exostosis that you should be doing a skeletal survey, or do you go on clinical grounds? Who thinks you should just go on clinical grounds? Yeah, if the patient tells you it's solitary. Good. Do you think that we should be following all these patients up because of the cancer risk later on? Who says yes, we should be following them up? Not many. Good. I think it's very difficult, isn't it? Because there is a suggestion that you could do a genetic test and that some genetic defects are more at risk of developing malignant change, but I don't think we know that for sure yet. And so we haven't got a screening process really to know whether we should be screening for the chondrosarcoma development in later life. So I think it's a difficult area that we haven't yet addressed. Anyone want to tell me about this tibial bow? Where is the apex for this tibial bow? Posteromedial, yeah. So is that a good thing to have or a bad thing to have? Good thing. I think I'd rather my child had no posteromedial bow, but I agree. Of the bows, it could be a good thing. Why is it a good thing? Yeah. Does it? Yeah, and I think that's true. We always used to teach that if you were just patient, that it would correct completely. I don't think that's quite as true as it's said. So I think most correct mostly, but you can be left with quite a significant shortening. So I'm not saying that's the biggest problem. We have, as you heard, we have simple and complex ways of treating a residual leg length discrepancy. But our evidence is of the cases we've treated. Now, that's not necessarily representative of the whole population of posteromedial bows, but there is a percentage that continue with a bit of deformity and certainly have a leg length discrepancy that you need to address. So it's a good thing to have of the bows, but just keep an eye on it and maybe follow it up. This is another bowed leg, a toddler bowed leg. You don't like that. So where's the apex in this one? Yeah. It is a pseudoarthrosis, and so what else should we be looking for? Yeah. So we really have to look quite actively. Even if we think it's not neurofibromatosis, we should look quite actively. In India, would you do a genetic test to look for the NF1 gene? No, nor would we, unless there was clinical signs to go with it. Okay, and I haven't got it. So what's think what I'm thinking now. What is the bow that I haven't mentioned? So we've had posteromedial, and we've had anterolateral. There's one more. The anteromedial bow, where there's no fibula. So that would be with your fibular hemimelia. Okay. This is the sort of thing we're looking for in our office, isn't it? With our externally rotated gait pattern. Mum says he never used to walk like this and now he's walking oddly. So what's the diagnosis? And which side? Both sides, exactly. My resident WhatsApped me with this photo and said, it's just a simple slip, Miss Eastwood. So I WhatsApped him back and said, which side is the simple slip? Because I don't know which side is the simple slip. Do you do any blood tests routinely when you see a teenager or a prepubertal teenager with a slipped epiphysis? Do you do that routinely? No. No. So the only thing that we do in England, because it's cold and dark and rainy, is that we do these days do a vitamin D routinely, because in England at the moment everyone is vitamin D deficient. And the treatment for everything is vitamin D tablets. And then maybe you should put a screw in the physis as well. But at the moment, vitamin D rules. So these brother and sister were both significantly deficient, and their general aches and pains were helped by vitamin D, and their slipped epiphyses were helped by standard orthopedic management with screws and things like that. Okay, this is a not very helpful picture. Anyone want to tell me what's happening here? Sorry?
It's a plain overboard foot.
Yeah, just a plain valgus foot. Okay. So what sort of questions do we want to ask? We had a very nice talk about flexible flat feet. What are we wanting to know then about this foot? Whether it's bilateral or not, and whether it's supple or not. So as the child goes up onto their tiptoes, does that heel come round? And if it doesn't, what are you worried about? Tarsal coalition. Yeah. And what would your favourite investigation be for a tarsal coalition? We heard the
CT scan.
CT scan. Okay, and what are you looking for? Just one coalition or more than one? Yeah. So I think the rule book suggests that you can have 2 tarsal coalitions in one patient. That's always a bit tricky. But the oblique views, I think, show you the calcaneonavicular coalition very well if you ask for it properly. And then when you have a calcaneonavicular coalition, would I normally go on to do a CT scan to look for a second coalition? I wouldn't. Would anyone else, if you found one coalition? No. Okay. And why do you go for a CT scan rather than an MRI scan? Anyone got any ideas? Antonio, do you always do a CT or do you do an MRI?
Usually, my assessment is first, of course, clinically. The second one is oblique view in order to detect. After that, if you are not really convinced or there is not detected assessment, the CT scan first, and sometimes the second option is MRI because there is some fibrous synostosis is not to be able to see with CT scan. So, and sometimes, as I show, there is some percentage of synostosis coalition is not visible on the CT scan. So it's better to, especially for the kids who are not the youngest one. I mean.
So our radiologists like us to start with an MRI. Then I always have to argue with them and say, what's this show? And they say, I think it's a fibrous coalition. I say, well, I don't operate on I think. So can we have a CT scan now? And recently we've also been using a bone-isolated SPECT CT scan. And that's been quite interesting in really highlighting areas of increased activity around tarsal coalitions. And it seems to be more sensitive than sort of bone edema. So maybe helping us to work out whether the coalition is in fact symptomatic or not. Do you have a low threshold or a high threshold for excising, say, the calcaneonavicular? If you just found it by accident, would you excise it? No. But if it was symptomatic, would you have a low threshold? Or do you make them wear boots or something like that for a while? Sorry? Would you? How many people would try treating, say, this calcaneonavicular in a boot or a orthotics or something like that? How many people would try that first? Okay, quite a few. All right. I have to say I've personally found those sort of not terribly helpful. I think orthotic supports, which are used a lot in the UK for treating a rigid flat foot. I don't understand how you can try and correct a rigid foot with a soft or a rigid orthoses. So if you want to just have a soft-soled shoe or a soft orthotic support to sort of shock absorb and make your foot more comfortable for walking, fine. But if you think your orthotic support is actually correcting the foot, I think that's very difficult to sort out.
So I guess we have to sacrifice the discussion and
Sorry.
at least no, it's okay. But we can have one case more, and that's it because you have to leave the whole.
Oh,
okay.
Or maybe any questions? Any questions on all the talks that you've had? Which one? Sorry, the tailored. So that one, I did an excision. It made her worse. So I went back and did a fusion, which made her better. But I thought, my assessment was that I thought it was quite a localized bar. I thought the rest of the posterior facet looked reasonably good. And I thought she was well aligned. So I expected this to be a good surgical outcome. And of course, that's the sad thing about surgery. I expected it to be good. I told her it would be good. She told me I was wrong. And then when I fused her, she was delighted. So, but would I do the same again? Probably, actually. What would you do? Fuse it straight, be more sensible. And what do you do with the calcaneal navicular when you've taken it out? What do you put into that hole? Fat. Okay. Anyone else? Put anything else?
I think it's very challenging cases because it concerns also the age. Because if those coalition is permanent for 10 years or even 11 years or 12 years, then you have a different compensation in other parts of the foot. And if you excise the coalition, this is not the end. That really, for me, it's very challenging. And I inform parents that we cannot achieve really the same results and on the other side, which is normal. So that's I think it's rather challenging cases. So it's not easy to really say that do all that.
No, exactly. And my friend, who's an adult foot and ankle surgeon, he has a foot X-ray that looks just like that, and he's not had any symptoms from it ever. So I think it's important to remember that it isn't necessarily the cause of all bad things happening.
Okay, I guess that's enough. I'm sorry for our delay. I hope that everybody is enjoying this session. There's several topics, and appreciate Debbie, me, and all the faculties who speak about this problem. Thank you very much.